a topic very dear to our clinic and to what we do in our program. And my hope today is to go through some of the basic anatomy of how the neck is organized and how that relates to headache or migraine, and then talk about how this can show up in the people that we care for and perhaps someone you know, and then most importantly, what the heck you do about it so that people can get much better and recover from recurrent chronic headache experiences. So I'm going to, first of all, start off by sharing what is migraine. And migraine, for those who aren't familiar with this, is a chronic disorder with episodic attacks in intensity. And this includes a very complex mechanism of inflammation of the lining of the brain and oversensitivity to some of these deep brain structures I've got on my screen. And what that can do is cause a migraine attack. And in migraine attacks, we see headache, which certainly is one of the most problematic features of migraine. But we also get a bunch of associated symptoms. And that can include light and sound sensitivity. That can include nausea. That can include numbness of an arm or a leg. It can also include cognitive impact, where people are slower than they want to be or don't feel quite like themselves. If you put all these together, that can lead to functional disability. And what that means is that people lose out on things they're planning to do for that day. So that if someone was planning to go to work, or if someone's planning to take care of their children, or if someone's planning to go to a family event or social event, if they have a migraine attack and it's severe enough in intensity, you can be incapacitated for that day. And if you get a bunch of these in a row, you can be incapacitated for a week or sometimes even longer. And certainly that's not a good place to be in if you experience recurrent migraine attacks. And here's the other neat thing. In between headache attacks, people are also more sensitive who are prone to have migraine than people who are not prone to have migraine. And what do we mean by this? That means that people who have had several migraine attacks previously are more likely to trigger a migraine attack with the same amount of stimulation to their brain or body as people who are more prone than people who are not prone to have a migraine attack in the first place. We also know that people who have episodic migraine are more likely to have anxiety than people who don't have migraine. And there's something called anticipatory anxiety. And what that means is that if someone's had a really bad episode of migraine the month before, and then they start having another migraine attack the next month, they're far more likely to raise anxiety about how bad is this going to be? How long is this going to last? How incapacitated am I going to be from this migraine attack that's occurring? And that drives behavior, so that folks are prone to overuse medications sometimes, or underuse medications because they're worried about how bad it's going to be and need to save up their treatments. We see that some people start reducing their expectations for the month in the concern that, well, if I do have a migraine attack, then I'm not going to be screwing up too many things in my life. And you see that at the workplace. Some people are not willing to take a job promotion or not willing to take on more work responsibility because they might be incapacitated from a migraine attack. And how embarrassing is it for yet again to call in to miss work, or yet again to call in sick because you can't be what you need to be or can't meet a deadline. So that becomes a major issue for people. And we also know that people who are prone to have migraine have a change in brain function, so that they start developing this thing we call a lack of habituation. What that means is that repetitive light stimulus becomes more intense over time. The body can't regulate a change in environment as well as we like them to. And they also develop a reduced pain threshold, meaning that the same pain stimulus applied to two people, if one person is prone to have migraine, they're going to have a more pronounced response of pain, even though the stimulation quantity is the same comparing a migraine person to a non-migraine person. We also see that people can have a escalation of symptoms over time. So someone can develop a beginning of a headache episode where they just kind of feel funny or weird, what we call a prodrome or premonitory symptom, and then that can sometimes get better all by itself. Or some people can get the beginnings of a migraine but also go into an aura experience where they get light visual hallucination that occurs and lasts for 15 minutes, 30 minutes, maybe up to 3 or 4 hours, and then that melts away. And not always do they get headache, but sometimes they do. And if that even progresses even further, you can go into an actual mild headache. Now, a mild headache, even if it's on the migraine spectrum, a mild headache can have just the headache itself without light or sound sensitivity, without nausea, all the things we think of migraine. But if that progresses even further, that can go into a migraine headache where people not only have the headache component to it, but also have light and sound sensitivity or nausea or numbness of an arm or a leg or fatigue afterwards. And if that continues to keep going even more and more intensely, the whole nervous system gets inflamed, and then you go into a full-blown migraine attack. That's where someone has light and sound sensitivity, nausea, and sometimes incapacitated where they can't do what they want to do from a day-to-day concept. So what does this have to do with the neck? And why the heck do we have this thing called cervicogenic headache? So let's look at what's pain-sensitive structures in the head, and then we'll look at pain-sensitive structures in the neck and talk about how they're related. So if we look at the head itself, the linings of the brain, these portions that we call the meninges, the lining of the brain, are very pain-sensitive. And you may be familiar with this concept of meningitis. Meningitis is an inflammation, the itis, of the meninges, which is the lining of the brain. So we most commonly see meningitis if someone's got a viral or bacterial infection of the lining of the brain. However, in migraine, the body triggers the same types of inflammation that you see in meningitis. So that even though it's maybe not as intense and it's not caused by a bacterial or viral infection, having recurrent episodes of migraine is very much the same, where there's a sterile but inflamed process that lines the brain and starts becoming more and more intense over time. And just like in meningitis, people with migraine don't want to move around a whole lot, have a throbbing, really intense headache, have light and sound sensitivity, and nausea. So that means that the lining of the brain is very pain sensitive. We know that the larger you get to the large draining veins in the brain, they also become more and more sensitive, so that there's actually more dense pain fiber on the central draining veins in the skull than there are elsewhere in the skull. We know the nerves themselves, which bring pain from the scalp, pain from the eyeball, pain from the cheek, pain from the teeth, and brings that pain information into the brain. Those are very sensitive areas of the head, and those are part of the pain-sensitive structures of the head, of course. We also know that the scalp and the superficial structures of the skull are also pain sensitive, and they bring pain information into the rest of the nervous system, just like the teeth areas do, just like the eyeball areas do, and all this feeds into the central area of the brain that regulates migraine and regulates headache. So why do we talk about this migraine nerve anatomy so much? And I think that's important to understand the big picture of migraine, the big picture of headache overall. So if you look at this picture, we've got the lining of the brain nerves shown in yellow, but they're also corresponding to the sensitivity of the face, of the cheek, of the forehead, which are called the trigeminal nerves. And anyone who's got a medical degree will tell you that the nerves that provide sensation to the forehead, cheek, and jaw are called these trigeminal nerves. But there's more to the story. So these trigeminal nerves also have pain fiber that goes up to the lining of the brain. So these nerves of the scalp and face, which also bring pain from the lining of the brain, called the meningeal nerves. These yellow trigeminal nerves bring this pain information into the brain stem itself. That's that center structure where you can see my arrow right here. And this is called the brain stem. And what this does is this regulates all of the incoming pain signal before it sends it up to the brain to be processed. So that when someone has irritation of the lining of the brain from a triggered migraine attack, it comes in through these nerves and gets processed in the brain stem, then goes up to the deeper areas of the brain to experience that. We know that this nucleus, this bundle of nerves that processes pain experience in the brainstem, goes all the way down the neck. And it ends in most people at C3-4, which is the middle portions of the neck. But for some people, that nerve bundle goes all the way down the neck and ends all the way down where the shoulders are, at this area called C7. So if you can envision all of this pain fiber coming in that relates to headache and migraine, going all the way down the neck, that's an important aspect as we talk about neck-related headache syndromes, meaning if something irritates the neck, and comes in the same area where there's migraine fibers, you can activate migraine from neck structures. Now, the one other thing on this complicated picture to show are the things called the occipital nerves. So these are nerves that actually begin in the same area of how that bundle of migraine nerves comes down the spinal cord and goes down the brainstem. And they exit from the back of the brainstem and back of the spinal cord, and they come up the back of the head and provide all the sensation for the scalp in the back of the head, but also provides the pain sensation for the deep structures in the back of the brain, too. And those are called the occipital nerves. And our job as headache specialists, and when you see your primary care physician or your local neurologist, their job is to take this overactive bundle of nerves that include pain to the lining of the brain, to the face, to the teeth, to the jaw, but also pain fibers down the spinal cord into the neck, into the back of the neck and up the back of the head, and take this overactive system and try and get it to calm down. And if you can get it to calm down, you can improve someone who's got chronic headache. So the next question is, how does this relate to someone who's got cervicogenic headache? Well, let's take a look at that for a second. So cervicogenic headache means headache that's being triggered or generated from the neck structures. So if we look at the neck and what's pain sensitive in the neck, we know that the joints of the spine are sensitive. That includes the discs in the spine, but also these side joints called facet joints. And I'll talk about that in a minute. We know that the bone in the neck is very pain sensitive, and the bone itself isn't, but it's got a lining around it called the periosteum that is pain sensitive. We know that the blood vessels that live in the neck, including some important ones you might be familiar with, like the carotid arteries or the jugular veins, those are pain sensitive, and if you irritate or injure those, that can generate headache. And we also know the muscle of the neck is very pain sensitive, especially the deep neck muscles that connect the skull and the neck together when you do little tiny movements. And I'll talk a bit more about that in a minute, too. So if you look at pictures, most people who see a physician and have got neck pain and also headache can get imaging of their spine, either an MRI or a CAT scan, sometimes x-rays. And what's become frustrating for a lot of our patients is that they're told that their imaging or their x-rays are completely normal, even though they've got persistent neck pain or headache that we think is coming from the neck structures. And the key there is that there may be some subtle findings on the MRI studies or CAT scans or x-rays that can explain headache, but don't relate to other nervous system problems. And what I mean by that is radiologists don't usually comment on things that don't directly pinch or squish on the spinal cord or the important nerves that lead the spinal cord. And I'll talk a bit more about that in a minute, too. So if you look at someone who's got just garden variety migraine, we know that people who experience plain regular migraine are prone to get neck symptoms. And that includes more than 90% of people who get neck pain as part of their headache. And if you look at the 90% of people who get neck pain as part of their headache, a third of them get it even before the migraine headache has started. Meaning that they say as part of their prodrome, as part of their wind-up experience for migraine, they get neck achiness. And our patients will say that. They'll say, I got this muscle spasm, this muscle irritability in my neck just aches. I just know I'm going to go into a migraine later today. That's kind of their warning before they go into a migraine attack. And as I mentioned, a lot of people get neck pain as part of their headache episode. But for those who get headache during a neck pain episode, they can actually feel like they got neck pain after the migraine attack has come and gone. And these are folks who say, well, my migraine was there for a day or two, that went away, but now I'm left with this really achy, naggy pain in the back of my neck and head. And I think this is kind of a referred pain phenomenon. What that means is that if you irritate the brain where we experience migraine, you can actually, as a side effect, irritate the nerves in the neck and get a achiness in a structure that has no problem primarily with itself, meaning there's no problem in the muscles, there's no problem in the neck, but you get neck pain as a spillover or a overactivation of migraine. And that by itself is quite common. Matter of fact, if you put on top of this picture a map of where people experience pain directly from the neck, you'll see that if you irritate structures that are high up in the neck, areas we call the C2-3 areas, you can get pain referred directly to the back of the head or side of the head for people who aren't even prone to get migraine in the first place. even more exciting is this picture. And this shows that if you take an electrode and you put it in the area where the neck and head come together, this area we call the C1 nerve root, and you turn it on, about 70% of people will get pain around the eyeball or pain around the temple, compared to about a third of the people out there who get pain in the back of the head as part of their migraine. We know that if someone's prone to have migraine in the first place, they're more likely to have pain referred from their neck into the around the eyeball areas or temple areas or forehead areas than people who are not prone to have migraine. Let me explain that one more time. So if you're prone to have migraine and something hurts the top portion of your neck, you're likely to experience pain around the eyeball or forehead. If you're not prone to have migraine and something hurts the top of your neck or neck structures, you're prone to get pain in the back of the head or maybe on the neck only. So that people with migraine have this enhanced nervous system that actually expands pain to areas where it's not supposed to go. This is an important concept because if something irritates the neck and you're prone to have migraine, it can fool physicians, it can fool family members, it can fool patients to think that the problem has nothing to do with the neck, when in actuality the neck may be a big problem or a big trigger for people. Now this next picture is designed to show that same nerve I mentioned briefly before, this nerve I got my arrow on called the greater occipital nerve. And the greater occipital nerve is the nerve that provides pain sensation to the back of the scalp, but also provides some pain sensation to the muscles deep in the neck, as well as provides some pain sensation in some people to the small joints in the side of the neck. This nerve is very important because if you're involved in an injury to the neck, either a whiplash injury or an injury where you're looking in the rear view mirror when you're hit from behind and you jar the top portions of your neck, or if you're in a fight when someone punches your face or punches your forehead and pushes your head backwards on an angle, you can actually squeeze or compress this nerve. And when that nerve is squeezed or compressed, you can get pain that refers to the back of the head if you're prone to have regular headache. But if you're prone to have migraine and you squeeze that nerve, that can refer pain all the way to the front of the eyeball for patients. That's called the occipital nerve. And the reason why this anatomy is unique is because this is one of the longest unprotected nerves in the body. It leaves the spine and it's got nothing around it to protect it. And it's got to run right between one of 3 different muscles to go through into the back of the scalp where it lives. And those neck muscles can become spasmed or irritated and can yank even further onto this neck nerve. So to summarize, this is called the occipital nerve, and it can get injured easily in traumas. And if you're prone to have migraine, this occipital nerve, when it's irritated, can generate pain around the eyeball, temple, forehead, or top of the head, or cause a whole head migraine. And that's unique to those people who are prone to have migraine. So the next thing is, if someone's involved in a motor vehicle trauma, what should you be thinking of? And I want to show this picture. So if you're minding your own business and then crossing the street and just get kind of taken out by a car there, we know that that can trigger or irritate neck structures and cause headache. Now let me first say no one was injured on the filming of this. This was from a movie scene, and that was a dummy that was placed in there. But it matters all the same. If someone's injured in a car accident, the head is a relatively heavy mobile structure. And when the head stops its motion, either because it rams into something or because of a whiplash, your neck is what has to absorb all the force of that head movement. And that can generate a lot of trouble for people. So I stole this description straight from the International Headache Society criteria, which is a document designed on how to diagnose headache. What this does is talks about cervicogenic headache as a one-sentence description of it. Headache caused by a disorder of the cervical spine and its component bony, disc, and or soft tissue elements, usually but not invariably accompanied by neck pain. Let me put this a different way. This is headache caused by a neck problem. You don't have to have neck pain to have a neck problem that can cause daily headache. So what are some of the signs or symptoms of people who've got a neck-related headache disorder? And so the first thing is headache. So headache can be mostly one-sided. It traditionally starts in the back of the head and escalates forwards as someone's pain escalates. However, I've seen plenty of my folks who've got cervicogenic headache in our clinic who have pain of the entire head, or pain that is only into the front. So this one-sided nature of it, or back of the head location, is more common, but certainly not required as a diagnosis for cervicogenic headache. Some people get migraine, which means not only do they have the headache component, but they activate the other pathways of hypersensitivity of the nervous system, meaning that they get light and sound sensitivity, or nausea, or fatigue, or yawning, or a bit of confusion as part of the headache episode. And that means that the nerves that have been irritated have turned on or activated migraine in those people. Neck pain is quite common, but as we talked about a second ago, not required for someone who's gotten cervicogenic headache. We commonly see reduced neck range of motion, which means that people have a harder time taking their chin to their chest or looking up to the ceiling if they've got a primary neck problem causing daily headache. And the other thing is people commonly describe cracks or pops or snaps or weird sounds that comes out of their neck. They also commonly say they need to crack their neck frequently to reduce pressure or to make themselves feel better. They sometimes say, if I can just crack at this one area, I'm going to feel much better, and that's going to take away my headache or at least reduce some of the pressure of my headache. And those are things that we don't usually see if someone has garden variety plain migraine. So as this picture shows, there's not one bullseye target that describes cervicogenic headache. It can be a bunch of things. And remember, I wouldn't want to be this guy. Who wants to be holding a target when they're doing target practice? So here's the diagnostic criteria from the International Headache Society on how you actually use history to decide if someone has cervicogenic headache. And really what I mean by this is a complicated way to describe how you diagnose this, but really the take-home points are the same as that other slide. It means that the headache has to be related to a neck problem. The headache has worsened or escalated as a known neck problem worsens or activated. It can be improved if you can shut off neck pain, and that's a way to diagnose cervicogenic headache, meaning if you can show that someone's headache gets better when you treat a neck problem, that's suggestive of cervicogenic headache. So I've got two people to put up here, and let's ask what they have in common. The first one is Clara Perel. And for those of you who are my age or older, you'll remember her as the Wendy's spokesperson who would say, "Where's the beef?" And the next person is Cain Velasquez, who's a UFC champion, meaning a fighting champion. And the reason I've got both of these folks' pictures up here is because if they show up to your clinic, or if you know people like this who come in with suddenly having daily headache, amongst the other things that can cause this, I want you to consider a neck-related headache problem. I've got Clara Perel here because she has, in her age group, you'd expect to see arthritis in the neck, and that can generate daily headache. So if someone in her age group shows up and says, I've got daily headache that started 3 or 4 years ago, us physician folks think maybe she's got arthritis in her neck causing daily headache, especially for headaches in the back, especially if it's mostly one-sided. Now, Cain Velasquez is certainly not in the age group of Clara Perel, but Cain Velasquez is exposed to trauma to the cervical spine on a daily basis. So if he says, I never had headache before, but now I've got this pain that starts in the back of my head and comes forwards, mostly one-sided. I feel like I've got to crack my neck all the time, and I got this background neck achiness. And by the way, I get light and sound sensitivity and nausea. That means that he's irritated his neck enough to trigger or irritate migraine. So he shows up looking like a young, healthy person with migraine, but in actuality, he's got a neck problem causing daily headache. So to look at this neck anatomy piece even a bit further, we can see that cervical facet pain can be a big problem. And I want to take your attention to this bottom picture. Here I've got the bones in the neck called the cervical spine, and I've got the side joints of the neck. This is nowhere near the cervical discs. This is on each side of the neck. This is where the two bones in the neck, when they rotate or when they look up or down, that's where all the motion takes place. And this yellow nerve that I'm showing that kind of provides the pain sensation to the side joints of the neck called cervical facets, this nerve bundle provides all the pain sensation here. So if you get arthritis or if you get a traumatic injury to a side joint of the neck, it goes and becomes activated by this yellow nerve fiber, which goes right into that trigeminal system, right into that migraine-sensitive pain system that we had talked about before. We know that you can worsen or irritate someone's facet pain, this is the side joint of the neck pain, by asking them to extend their neck completely, or by asking them to twist their neck left or right. And people will sometimes say, I get this click and pop, and then my pain goes really crazy afterwards. And many times that means that they've got a facet problem, a side turn of the neck problem. Sometimes if you see a doctor and they're worried about a facet problem, they'll press on the side joints of your neck. So not deep in the center, but off to each side. If there's one spot that makes someone cringe in pain or activate in pain, it makes you think that they may have cervicogenic headache. Now, these side joints of the neck are very pain sensitive. They're fluid filled, just like our finger joints. And if you bruise them or irritate them, they generate pain. The deal is, if you're prone to have migraine and you've got a facet problem, that can turn on migraine for people, even though you can have just an arthritis issue of the side joints of the neck. So certainly if you have someone who's in their 50s or 60s who develops out of the blue daily headache that starts in the back and comes forwards, and is mostly one-sided, and they've got arthritis in their family, or they themselves have arthritis in their body, most physicians would be very suspicious of this thing called cervicogenic headache. To talk a bit more about arthritis, I like to show these two pictures. So this picture right here shows a healthy bone in someone's neck. This is the facet joint, the side joints of the neck, and you can see here it's healthy, where you've got a nice clear flat lining of bone from the top bone, and the bottom bone has a nice clear flat lining to it also, and those edges line up relatively well. Now the bottom picture, I've got the same kind of bony picture, but this is someone who's got arthritis. So first of all, you can see there's a raggedy appearance of that same joint compared to the joint up here. And you can see that there's bumps and lumps and growth along the edge of these bones, suggesting growth of arthritis. When they look at dead bodies, called cadaver specimens, we know that the most common place to have a problem with the cervical discs in the neck is in the middle and lower portions of the neck. However, the most common place to have a problem with the side joints of the neck is in the middle of the neck, what we call the C3-4 and C4-5 areas. And if someone has severe arthritis of the side joints of the neck, the most common place that's going to be is the C2-3 region, which is the top portions of the neck. And why that's so important is because the top portions of the neck are the closest to migraine nerves and the most likely to generate migraine if they become irritated or activated from arthritic pain. I'm going to show you that same picture I showed of the side of the neck. And here I want you to look at this joint right here that we already know is arthritic. And I'm going to put on top of that picture an MRI picture. And what I'm showing on this is what an MRI looks like for someone who's got a facet problem. And let me show you what I mean by this. I'm going to put a red arrow on it. But you can see from this picture, these are the side joints of the neck, so not the discs. But you can see that there's these grayish boxes, which are the bones. And you've got these black lines, which represent the joints themselves. And then this one's got this large bump that hangs off of it, and that's all arthritis. So this person's got substantial arthritis between the C2 and the C3 facet, and that's called a C2-3 facet arthrosis. What that means is if this person shows up with daily headache, and they've got this kind of MRI, you can dramatically improve their symptoms by targeting therapy to this region. I'll talk a bit more about that in a minute too. But that's what MRIs are helpful for when you look for cervicogenic headache. Now, how about whiplash? What happens in that situation? So don't do this at home. This guy's going to try and catch this exercise ball, and of course he hits himself in the back of the face, and his head goes flying backwards. Here it is in slow motion. Look how fast his head goes backwards. And when you see that type of motion, one wonders just how much strain and wear and tear is that not only on the joints of the neck, but also the muscles and ligaments that have to hold all those things together. Now, if someone gets an injury like a whiplash type experience, they can get muscle injury, which causes the deep muscles of the neck to become swollen, to become thicker or fatter than most people, and you can get symptoms of how the neck moves that causes trouble from that. Let me show you this picture. This is going to be hard to understand if you're not used to how the neck looks like in the first place. But let me talk to you about what I'm trying to show here. This is the top portion of the neck where the brain comes right on top of the spinal cord. And here what I'm showing you is itty bitty tiny muscles that connect just underneath where the skull connects to the neck. These small muscles have filaments and connective fibers that attach not only to the bone around them in the high neck areas, but also connect directly to the lining of the brain or directly to the lining of the spinal cord. so that if they get spasmed or irritated from a whiplash injury or from trauma, those muscles can yank or pull or become spasmed so much that they irritate or cause pain to the lining of the spinal cord or to the lining of the brain. And patients in this situation say, I've got this background yanking sensation in the back of my head, and I've got this horrible, intense headache that occurs in the back of the head that's there 24/7. Now, the headache may not be there all the time. It can come and go, but that achiness of the muscle, that pulling sensation, is usually there all the time. And those are people that we think of a primary muscle problem generating daily headache. So here's a patient of mine, and watch what happens when we ask her to move her chin down to her chest, or to look all the way up to the ceiling. And I'm hoping those watching from home see chest, the neck in general. She's got so much muscle spasm that her neck doesn't move the way it's supposed to. I'm going to show that one more time here. So you ask her to take her chin down to her chest, and instead of being able to touch her chest with her chin, she can only go down that far. When you ask her to look all the way up to the ceiling, she can only go up a little bit until her whole neck locks up. When you ask her to look to her left, same thing. She moves a bit, and then her whole shoulders have to turn for her to look behind herself. You ask her to turn to the right, same thing. So she's got something called cervical dystonia. And cervical dystonia, also known as torticollis, is where someone has enough sustained muscle contractions that result in abnormal postures of the head or neck. Now, these folks typically show up with neck pain as well as a tremor of their head. And that can be really subtle, that their head shakes a bit, but they've got daily headache and many times a pulling sensation in the back of their neck or head, almost a persistent squeezing that they just can't get rid of. Now, the extremes of cervical dystonia cause all kinds of things that we call retrocollis, anterior collis, or torticollis. What it means is that people have so much muscle spasm that it yanks their head out. Showing this picture, sometimes they can look normal until you ask them to move their neck, and their muscle spasm reduces their ability to move the neck the way it's supposed to. Instead of having not enough motion because of muscle spasm, the flip side is people who've got hypermobility. So that if you test people at a headache clinic, more than 10% of people who show up at a headache clinic are going to have what we call hypermobility compared to a smaller number of people who show up at the regular primary care's office. And really, this is a way of helping explain why some people are prone to have problems with how their neck moves and operates compared to others. So people who are more flexible than other people are more prone to have daily headache, but also more prone to have chronic pain syndromes than people who do not have hypermobility. And there's all kinds of reasons that are beyond the scope of our discussion today that can relate to that. Here's one picture I do want to show you. This is a patient of mine who actually has hypermobility, which you can see in her hand by her thumb touching the wrist easily and her fingers going beyond 90 degrees. But look how her neck rotates. So this person can certainly rotate her neck with ease beyond 90 degrees and takes her ear to her shoulder with ease. And this person, in addition to other health issues, has had some muscle pain problems in the top half of her neck. So if you want to help people with daily headache, how do you do this? And the way that I want people to think about this is when you talk to your physician, when your physician is trying to help you, this is an important aspect of what's going to happen. So don't be this guy. This is the guy who's asked to bring up the rings when the priest asks him to. So this guy says, please bring up the rings to help with his wedding. And this guy slips and knocks over. The priest knocks over the bride, sends them into the water, and really what was a good intention, this idea of trying to get help, trying to provide help, resulted in a bad outcome that these people would just never forget for the rest of their lives. So how you help will have a lasting impression with this. And I want to talk about some things you can do to help someone who's got cervicogenic headache. So there are certainly medications that may be effective in cervicogenic headache that do not seem to be effective in other headache syndromes. And some of these let's talk about in a bit more detail. In our program, if someone has cervicogenic headache, we usually focus on medicines like duloxetine, sometimes tricyclic medications, and we also focus on topiramate or gabapentin or pregabalin. And I do want to take a couple minutes to talk about these medications, or some of these at least. The first one is topiramate. Topiramate is a very effective headache prevention medication. It's been commonly used in this country for at least 15 years to prevent migraine, and certainly can be effective for someone who's got cervicogenic headache. The typical effective dose in this medication is between 50 milligrams a day and up to 200 milligrams per day. However, we've got some people in our program who respond to just 15 milligram sprinkle capsules, one of those a day. And although not in my practice, we've had reports of people responding at doses upwards of 1,000 milligrams per day. So this has a very wide range in dosing. In the beginning, it can be taken just at nighttime. And why that's important is because young, healthy people who've got chronic headache have a hard time remembering to take their medications. So once a night is more likely to be done on a regular basis than twice a day or 3 times a day. And in the case of migraine prevention or cervicogenic headache prevention, it seems to be just as effective taken once at night as opposed to be taken throughout the day. There is a very rare chance of kidney stones, but it's something worthwhile mentioning. And this medication is typically effective within 1 to 2 weeks of achieving a therapeutic dose. Now that's very different than being effective in 1 to 2 weeks of starting the medication, because you've got to slowly build up on this medication. Now most people on topiramate, which is also known as Topamax, most people on topiramate rarely have side effects. But those common side effects worthwhile talking about include paresthesias, which is a fancy way of saying tingling of the hands and feet, even sometimes lips and nose and mouth. And that can be treated, if someone has that, with drinking electrolyte sports water or increasing their water intake. And the reason why this paresthesias occur is because Topamax has this unique ability to separate electrolytes like sodium and potassium and chloride from inside the cell and outside the cell in the nervous system, which gives you a hallucination of sensation. That's that weird tingling like your hand and feet are falling asleep, even though it really isn't. And if you drink a lot of electrolytes or put a lot of electrolytes in your body, the body reduces that side effect. Now, it's quite rare that we tell every one of our patients to look out for cognitive slowing. This is almost never permanent, but this cognitive slowing is most commonly manifested by word-finding troubles. So people on this medication say, I tried to think of the right word, but I just couldn't get it out. Or they say, I know what I'm trying to write down, I just can't put the words on paper. And it's that word-finding issue that is quite common with topiramate. And if you just reduce the dose or switch it all to nighttime, this typically fixes that issue. We also know that some people on topiramate can experience depression. If that happens, we always stop this treatment. And then the one side effect that we hear the most about on topiramate is actually weight loss, because a percentage of patients on topiramate establish weight loss that they seem to be pleased with, and that's really a selling point sometimes when patients are trying to decide should they go on that therapy. Usually it's between 5 to 10 pounds, and it is partly because foods taste kind of funny on this medication, but all the same, some people can lose between 5 to 10 pounds when they're on this medication. Now, another medication we use sometimes for cervicogenic headache is something called nortriptyline. The brand name for this is Pamelor, and there's other names for it too. It can be very effective for some people. It's inexpensive. Almost every insurance covers nortriptyline without any questions. And it can improve sleep quality in addition to preventing headache. Our programs typically start at 25 milligrams each night. We can go as high as 75 or 100 milligrams, and some physicians go even higher. If someone's on this medication, there's a rare chance of side effects, including morning fatigue, increased appetite, anticholinergic side effects, which means lightheaded if someone stands up, or worsening of memory. And if someone's been on this medication for years and years and years, we have to wean them off slowly. Nothing bad usually happens, but if you go off too quickly, people get funny heartbeats and feel a bit unsteady. If you go off that medication slowly, that can be a way to avoid some of those issues. Now, the next group of medicines to talk about includes SNRI class medications. Duloxetine, which goes under the brand name of Cymbalta, amongst others, is a medication that seems to be quite effective for cervicogenic headache. We typically start off at 30 milligrams each day, but sometimes go as high as 60 milligrams twice a day. And the benefit of the duloxetine medicine or other SNRI class medications for cervicogenic headache is that they work on a molecule called norepinephrine. And norepinephrine plays a substantial role in processing nerve pain coming from the neck or head. Last medication to cover, so don't bore everyone listening in, is something called Pregabalin. And this is very similar to a medication called Neurontin or gabapentin. And in our program, we typically start this medication at a very low dose and dose it only at nighttime because it can improve slow-wave sleep, and if you use it only at nighttime, it seems to be effective in some situations for headache prevention, especially cervicogenic headache. But indeed, it can improve other centralized pain syndromes such as fibromyalgia, such as trigeminal nerve pain syndromes, and overall can be quite effective because we know people with cervicogenic headache typically have a reduced sleep efficiency, meaning they fall asleep but they don't feel rested upon awakening. And this medication can improve that. So there are some medicines that seem to irritate or bring out worsen migraine if they're overused. And this cartoon says, "Have a seat, Kermit. What I'm about to tell you might come as a big shock." And the reason why I bring this up is because if someone has a background neck pain or background low-grade headache and they're not sure where it's coming from, and they go into their local pharmacy, they may use a medication like Excedrin migraine. And if that's effective for them but becomes less effective over the course of a couple months, they're going to go back into that same pharmacy and they're going to choose something even stronger. And that might be something like Excedrin Extra Strength. If you're listening along at home, you might think, what's the difference between those two medications? Well, it turns out there is no difference between these two. We know that the ingredients are exactly the same. They're made in the same factory, just one gets into a green and white box and is labeled Extra Strength, and one's labeled Excedrin migraine and gets put in a maroon box. But both of these medication boxes contain tablets with 65 milligrams of caffeine per tablet. And the problem with caffeine is if you overuse caffeine, it can irritate or bring out more headache for people. And if someone starts irritating the migraine pathway, they start having low-grade persistent squeezing headache. And they'll go back to the same pharmacy and use this medication, which also contains caffeine. If you start turning on more and more migraine nerves because of caffeine irritating or bringing out sensitivity to these nerves, you can get eyeball watering and nasal stuffiness, leading someone to then reach for an additional medication called Excedrin sinus headache. And if you do 65 milligrams of caffeine, and you do that frequently throughout the day, which some people end up taking 8, 10, 12, 20 tablets per day, their sleep goes bad. If they have poor sleep, we know that can bring out centralized pain and irritate pain fibers. And if someone's not sleeping well, they may add an Excedrin PM, which is, thank goodness, got no caffeine, but it's got Benadryl. And if someone doesn't sleep well, one of the most common symptoms of poor sleep, even in young, healthy folks, is muscle achiness and headache. So then they're back to the same spectrum. So those are some medication options. If people are looking for non-medication options to treat cervicogenic headache, we would want people to consider the following. The first one is using magnesium, and magnesium is already in our bodies. If you take extra, it acts as a muscle relaxant, as well as reduces migraine all by itself. There's also a supplement called Boswellia, and Boswellia is a root extract from South Africa. There's a name brand that was designed specifically for headache prevention called Glycin. And Boswellia seems to have an anti-inflammatory benefit similar to ibuprofen, similar to indomethacin, similar to other NSAID class medications, but doesn't seem to have the same stomach irritation as other NSAID class medications. Butterbear's become quite popular as a vitamin supplement, but certainly there's been recent evidence suggesting it can irritate kidneys, and we don't recommend that so much in our program. And lastly, if someone has an inflammatory or hypersensitivity or allergy type component to their cervicogenic headache, sometimes quercetin can be an effective option. Quercetin is a grapeseed derivative that works on reducing inflammation through both histamine as well as other inflammatory markers. How about alternative therapies? If someone's got cervicogenic headache, are there ways to help people feel better without using tablets of any kind? So let's take a look at a few of those things. First thing is physical therapy. In our program, and myself, I'm a big believer of hands-on therapy, either reducing muscle irritability in the back of the skull or neck, or from doing something called craniosacral therapy, which is a way to kind of augment cerebral spinal fluid flow from the lining of the brain and down to the spine areas. Certainly, acupuncture can be effective for some people. Downside on acupuncture is cost, because it's not usually covered by insurances, as well as accessibility, because there's not really acupuncturists on every corner. However, acupuncture has been shown to reduce chronic tension type headache, as well as some components of cervicogenic headache. Chiropractic can be very effective, although I typically suggest our patients to not have high-velocity cracking maneuvers of the top of their cervical spine. But in general, hands-on therapy with chiropractic can be quite helpful for cervicogenic headache. And many times, chiropractors are the most knowledgeable of cervicogenic headache compared to other providers patients might seek out. And of course, we've already mentioned vitamin therapy. So what if these things don't work? What do you do? And I've had some patients who say, I just got so frustrated, I just stopped treating my headache. I just came to decide I'm just going to have daily headache for as long as I'm going to have daily headache. And indeed, I think that might be the stupidest thing that's ever been done. Check this guy out. So this guy jumps out of an airplane, and tell me, what is he missing? This guy's got no parachute. So that's pretty stupid. This guy's pretty chill for jumping off an airplane with no parachute. He's just chilling backwards on his back. And I'm going to stop it right there because this guy's kind of a knucklehead. Now, I'll tell you, he certainly lives. He has a friend who has got a parachute that dives down to save him, locks him in, and away they go down to the ground. But my point in showing that video is that if you feel like you've got cervicogenic headache and feel like no one's helped you, and those typical things I've already mentioned aren't effective, I want you to listen to these other options. So the first thing is something called an occipital nerve block. And this is where a physician takes numbing medication and places it underneath the skin as an injection on the back of your scalp. Now, I know this sounds completely scary and crazy, but I'm here to tell you this is a very, very safe thing to do. The medicine just goes in the scalp. And in our program, we say this is very similar to when a dentist numbs your tooth before doing a dental procedure. When this is done, there's a sting. It stings for about 10 seconds, and then that sting goes away. There's a patch of numbness that comes up the back of the scalp, but that numbness only lasts for about 4 to 6 hours and goes away. What it does is send calming signals from the nerves in the back of the scalp that also relate to the high neck area, and sends calming signals to that deep area of the brain that regulates chronic migraine and cervicogenic headache. So this is what it looks like when someone has it done. We have someone sitting in a chair. Their chin goes to their chest as much as they possibly can. The clinician feels where the notch is in the back of their scalp where the nerve likes to be, and they just wipe it down with a prep pad. Once that spot is found, it's wiped down and the medication is taken out and injected. Let me show you what this looks like because I've got a video of this. So here's a patient of ours. We've already identified the spot we want to go for. We press in the back of the scalp. I hope this doesn't bother anyone to watch it in. And there's a little bit of a poke in the back of the scalp. If you're squeamish, please turn away. There's a poke in the back of the scalp. The area is found where the nerve is. And then numbing medication is placed. And this all takes all of about 5-10 seconds. I'm going a bit slower just so the video can catch this. But the medication is placed in the back of the scalp. And then that's it. All finished. And this can be a very effective way to knock out that reflexive loop of pain from the high neck, triggering migraine headache or triggering other headache subtypes. If occipital nerve blocks aren't effective or not selected, there's other things that can be done. And this is where a specialized physician who's got extra training in treating high neck pain takes a numbing nerve injection, but instead of doing it in the scalp, does it lower into the spine. And what I mean by that is those top neck joints that come together and cause arthritis for some people called cervical facets can be numbed with an injection needle. And if that works, you can actually, instead of injecting numbing medicine, you can actually heat up that nerve and make it last for 6 months to up to 2 years. And that is an effective option for people who've got arthritis in the high portions of the neck, or people who've got motor vehicle trauma and daily headache. And the neat thing about this is most people don't have side effects. Certainly there's some discomfort in getting this done, but a lot of my folks will want to trade a little bit of discomfort for long-term payoff. So this is something we strongly consider in our program if someone's got arthritis at the top of the neck, or if someone's got trauma that's affected the top of the neck and has got daily cervicogenic headache. So I've got just a couple more minutes, and I want to make sure I answer whatever questions that have come through from the board, if any have been submitted. And I think I may as well buzz through this so I can answer those questions. Let me get to my conclusion here, and I'll talk about this stuff if there's questions afterwards. But really, what I'm really trying to say with cervicogenic headache that if someone, and then let me show you this picture too. This is a guy who's trying to break the world record. And my point here is if someone has cervicogenic headache, it can be a long journey. It can be a long, frustrating experience where patients know that the neck is a problem, the clinicians know their neck is a problem, but they don't really quite know how to explore it further, how to identify it further, how to understand what may or may not be a problem, and then what to do about it. So if we look at this, people who've got cervicogenic headache can have headache, they can have numbness in the back of their scalp, they can get clicks and pops from the back of their neck, they can have swelling or muscle spasm, they can have range of motion problems where the neck doesn't look up or down the right way or left or right the right way. And if you identify a neck structure that's generating daily headache, you can treat it differently than you would typical migraine. Medications that have not been shown to be effective in migraine, like Neurontin or Lyrica, also known as Pregabalin or gabapentin, can be very effective in cervicogenic headache. Nerve blocks, where you take numbing medicine and place it underneath the skin to shut off nerves related to daily headache from the neck, can be very effective and very safe to do. And also, injections under an X-ray machine to the high joints of the neck to shut off triggers from arthritis or trauma that cause daily headache through migraine nerves can also be very effective. If you do all of this, you'll make it through that long journey with a pleasing outcome. So let me see if there's any other questions that have come through by our moderator.
All right, our first question here. Can a cervicogenic headache be caused by poor posture while driving or working at a computer or even from sleeping with the wrong kind of pillow?
Yes, and the short answer there is, can it be caused by driving in the car? Certainly I've seen that before, where someone actually goes into a neck spasm or neck irritation from that, and that can over time build up and make someone who's prone to have migraine go into daily migraine because of that. So yes, I've seen that. Now from a poor pillow or having poor posture, many times we see that more as a symptom. So that if someone's prone to have cervicogenic headache, they start developing sensitivity to how their head's placed when they go to sleep. They start developing sensitivity to how their pillows are arranged or how their bedding arrangement is arranged, so that they start trying to protect it because they know that if they do any minor issue, it can start causing all kinds of trouble for them. So, so certainly I've seen that before, and I've seen that escalate someone's symptoms. But if someone says that their headache gets worsened from driving, or that their headache is worsened from pillows, or because they've been told their posture is poor, I would tend to agree with them. And usually I'd want to bring that up to my clinician, see if he or she has ideas on how to help that going forwards. And if someone has had a lot of recurrent headache and just not seen much progress, then I'd want them to explore this cervicogenic headache pathway. Are there other questions out there?
Yes, thanks. Our next question. She says she thinks she's experiencing cervicogenic headaches. I have a bulging disc in my neck, C5, as well as a slight case of scoliosis. However, neurologists and headache specialists deny that there are that these are the culprits. Is it possible for cervicogenic headaches to be resistant to medication and unremitting? I've taken NSAIDs, muscle relaxants, antidepressants, etc. to no avail. The pain never goes away. I've had a headache every day of my adult life, and I'm now over 50.
Wow, so that's, I'm really sorry to hear that. That sounds like a very intense experience. And so to answer the question, certainly it's worthwhile pursuing, and I'm not able to give direct medical advice to people over the line like this, but a C5 disc herniation by itself theoretically can cause headache because there's such variability in the human nervous system. So that if we look at cadaver specimens, dead bodies that are cut open, the nerves of migraine for some people end higher up in the neck, but for some people they end lower, even below where your disc herniation is from, so that's possible. However, if I heard that story for someone in our clinic, I'd be even more excited about the mild scoliosis issue, because people who are prone to have scoliosis, because they've got some twisting of their normal spine anatomy, that means that some joints in the neck, these things called cervical facet joints, are going to bear more pressure or more strain than others just by the nature of a subtle twist or spin in the spinal cord or in the spine itself. And so we will be hunting in our program for cervical facet problems in that situation. And the issue about this is that many neurologists are told, many physicians are told, that if someone has a problem below C2-3, it can't cause cervicogenic headache. And that concept has been completely refuted and found to be not true, but some people still hold on to that. So if someone hasn't responded to typical treatments and has other signs and symptoms suggestive of cervicogenic headache, I would certainly want to explore that possibility. And you may want to discuss this with your treating physicians, maybe even ask about things like an occipital nerve block, or ask about a referral to an interventional pain specialist to consider high cervical facet blocks to see if that may be playing a role for you.
Our next question. What about Cymbalta since it hits more norepinephrine receptors than Cymbalta?
I'm sorry, what about which medication?
Sevilla?
Oh, Savella. Oh, it's funny. What an insightful question for whoever presented that one. And that is a fair statement to make. In preparation for this, I literally deleted the statements on Savella, which is brand name milnacipran, because I didn't want to provide too detailed or complicated information for those listening in, appreciating there's various interests and various backgrounds in this. But certainly we do use milnacipran, also known as Savella, in our program. It's one of the medications that in this country only has an FDA approval for fibromyalgia, so that many of the insurances around us are hesitant to allow us use of that medication when it's being used off-label for cervicogenic migraine or cervicogenic headache. But certainly that's a very reasonable idea. And the only reason why I didn't include it was because I was trying to be brief and succinct.
Our next question, can you please speak more on surgical treatments for occipital nerve compression?
So this may be one of those questions that's asking a whole nother question altogether. So that there is a trend in this country for surgery to reduce pressure on the occipital nerves. And there are some physicians who are advocating doing a minimally invasive surgery to reduce pressure on the occipital nerves. And if that's the question, I'd like to share that this has been looked into quite extensively about 10, 15 years ago. And we know that the nerves in the back of the head, these occipital nerves, are in every single cadaver specimen studied who did not have migraine headache or the headache syndromes. They always have an indentation from a blood vessel or sometimes from a muscle onto the nerve. So indentation by itself doesn't cause problems. And almost always we can achieve similar or even better improvements from doing nerve block procedures or other targeted treatments than doing a surgical intervention if someone has a severe occipital chronic headache issue. The downside of surgery is it's permanent. So if you're a young, healthy person and the surgeon tries to help by doing a decompression surgery, that can cause all kinds of trouble down the road, such as nerve pain, such as scarring, and other issues. So in our program, we typically don't endorse that. Now, if that wasn't the question, someone's just asking specifically about if you've got a mechanical irritation of the occipital nerve. Certainly, one easy place to start is vitamin supplements like magnesium or maybe even boswellia. The second thing is doing physical decompression treatments, including those either from a physical therapist or from an excellent chiropractor. One more time, just stating we typically don't endorse cracking maneuvers at the top half of the neck in our clinic, but other things that chiropractors have to offer can be quite effective in this venue. And then there's other ways to try to decompress that through other types of specialized physical therapy, even including something called occipital decompression treatments, where the clinician curves their hands and gently applies traction, as well as direct muscle activation with their fingers on the muscles that connect the back of the skull near the occipital nerves.
Thank you. Our next question, do all nerve blocks contain anesthetic?
So that's a great question. A nerve block, by definition, contains anesthetic, but there's various types of anesthetic that are used. Let me give you for an example. in our program, if someone's got cervicogenic headache or chronic migraine, we typically use an anesthetic called bupivacaine, which is a numbing agent that lasts longer than lidocaine. In our program, we almost never use steroid medicine for our occipital nerve blocks for cervicogenic headache, mostly because it appears that the benefit from the nerve block is from the anesthetic and not from the steroid medication in those situations. So we typically don't use it. Some clinics use strictly steroid medicines, and those are somewhat considered nerve blocks, but technically a nerve block is an anesthetic medication. And some clinics combine numbing medicine plus steroid. And then the next thing is some clinics will even do nerve blocks with other types of agents, botulinum toxin and a few other things. So even though the term specifically does refer to an anesthetic agent, it doesn't always mean that's what you're going to get if you're seeing a clinician for it, and it's worthwhile. The one other thing about that, if the numbing agent only lasts 4 to 6 hours, how can it help me for 4 to 6 weeks? And the idea is that you provide a numbing anesthetic to a peripheral nerve, a nerve in the scalp, that sends a calming signal to the deep brain structures that process chronic migraine and relieve that chronic migraine experience. And the duration of benefit has nothing to do with how long the numbness lasts, but how long it takes your own nervous system to wind back up into that headache pattern. And that's why some nerve blocks provide a couple hours of benefit. Some nerve blocks, for some people, can provide 6 months or longer. And if you take all comers to a headache clinic that gets an occipital nerve block, the typical duration of benefit is 4 to 6 weeks.
Our next question, is it possible to have an underlying migraine disorder that is exacerbated by cervicogenic headache so that migraine may still be present despite control of cervicogenic source?
Yeah, what a great question. So certainly migraine, if you irritate it enough, can go into chronic daily headache and chronic migraine regardless of what initially triggered it. So we sometimes see that if someone has enough neck problems, they can turn on or activate migraine. And even though you get the neck problems under control and those are improved, you still got to calm down that chronic migraine piece. So the short answer is yes, although usually you would expect some improvement of the headache pattern after eliminating the neck component that's triggering or bringing out that experience.
Our next question, can you speak to the best optimal treatment for mild scoliosis plus facet arthropathy?
Yeah, so if someone has mild scoliosis and has some mild to moderate facet arthritis or facet arthropathy, what we typically do is look at manual treatments as well as vitamin supplements first, depending on the severity. The next thing that we typically focus on in our program is using peripheral nerve agents with minimal side effects, such as the Pregabalin or gabapentin type medicines or the SNRI class medications. If someone still doesn't respond to that, we typically then look at doing easy and safe, effective peripheral nerve blocks, like an occipital nerve block, or trigger point injections of the neck muscles that connect the neck and head together, both of which are incredibly safe and are very effective for some people with some minimal discomfort just for a couple seconds when you do the actual procedure.
Our next question, what is the difference?
And one last thing to add into that is if someone has enough facet arthropathy, I would even include a referral to an interventional anesthesiologist to consider cervical facet blocks where the arthropathy is. Sorry about that.
Oh, no worries. What is the difference between magnesium glycinate and oxide?
Oh, what a great question. So magnesium oxide is inexpensive. It's available at every single pharmacy I've ever seen that sells supplements. And it's a relatively well-absorbed supplement. Magnesium glycinate seems to be even a little bit better on headache and better on muscle pain in our experience than magnesium oxide. But the downside is that it's usually only available through special order or at vitamin specialty shops. It's usually a bit more expensive, and they're usually larger tablets to take. So that our people who are looking for the absolute best magnesium no matter what, we usually recommend magnesium glycinate. For our patients who are willing to take magnesium but certainly are hesitant because of tablet count or inconvenience and want to just be able to get it wherever they can, they can use magnesium oxide. I think both are effective, and magnesium glycinate is probably the best one, and magnesium oxide is a close second place finisher. The rest of the kinds of magnesium, in our experience, are less effective than those two that I mentioned.
Looks like that was our last question for this evening. Dr. Cooper, we'd like to thank you again for covering this topic. It was very well received. Everyone's pleased. They're sending in very nice comments about you. I'd like to let everyone know we are having another webinar next week regarding the comorbidities, psychiatric comorbidities of headache. So if you could join us, and Dr. Cooper, if you'd like to give a closing statement.
I sure would. First of all, thank you so much for your interest. Thanks for allowing me to spend time and discuss this really cool topic. And for those who do have chronic headache or have loved ones with chronic headache who seem like they have cervicogenic headache, don't be shy in bringing this up to your clinicians because sometimes they need some prodding along to really reconsider this. And certainly in our clinic, we see great responses from this when we finally appreciate this is a path that's prone to lots. So keep the faith, and thank you very much for your time and interest tonight.